Senator McGuire, good afternoon.
Hey, good afternoon, Mr. Chair. So support on both sides means about
keep it
15
short.
minutes?
Means keep it short.
15 minutes, all right.
Because otherwise, if you talk too much, it'll turn into a close.
That's what I'm saying, feeling the love, a hot day. All right, let me just rearrange this to make this quick. Okay, there we go. There's only 20 pages here, so it's going to just take about 12 minutes. Hey, there we go. All right. Mr. Chair, good afternoon. I will make this short, and I do appreciate all the work, Mr. Chair, that you put into this along with your staff in regards to the evaluation, and thank you for allowing me to be here today. Briefly, there are about 5,000 children statewide with severe long-term, complex, and catastrophic health needs who are eligible for Medi-Cal in-home nursing care. Most of these kids are permanently disabled, medically fragile. They may be on continuous life support or require life-sustaining equipment such as ventilators and feeding tubes. And we're talking significant healthcare needs such as heart defects, traumatic brain injuries, or were born prematurely. The problem that we face here in California is only 50 to 60% of these kids are getting the care that they need. I'm going to go through some statistics, then I'll turn it over to our witnesses, Mr. Chair. So what we know is that it is better for the state and it is better for the patient if the child is treated at home with a skilled medical professional. What we also know is it costs 10 times more each day to care for a child in a hospital than it does for a child at home. And despite 2 requests, one in January, one in March from the Department of Healthcare Services, to determine what that cost differential may be, we've yet to receive a clear answer from the department. So what we can say from the state of Washington, it's $5,000 per day for a child in a hospital or $500 per day in home. And over the last decade, we've seen significant barriers to care, long waiting lists that can last literally for years, or if you live in a rural county, there are no in-home care options. I'll finish it up in 2 minutes. Right now, we have 1,200 home health agencies in California. Only 400 of those home health agencies actually accept Medi-Cal. Only 300 of the 400 are accepting pediatric Medi-Cal. Moreover, 60% of the 300 home health agencies that accept pediatric Medi-Cal are only able to provide 25% of the coverage that is needed for each juvenile that is on Medi-Cal. Plus, there are caps on private care for 200 hours. So what this bill would do is focus a pilot project on 3 areas in the state: Los Angeles, the 9 Bay Area counties, and the Central Valley. And the reason for that is the most acute shortages of staffing in home health agencies exist in those areas. This pilot project would cost $7 million on an annual basis. But by the way, it is federal law that we have to fund this program, and we're not. For every dollar that the state puts into this program, the feds will match with another dollar. So to expand this with a 20% bump for Medi-Cal, for pediatric Medi-Cal, would be $7 million from the state, $7 million from the feds, for a total of $14 million. Knowing that we have support on both sides, and I do want to say thank you, would like to let you know the American Academy of Pediatrics, the Children's Hospital Association, Children's Specialty Care Coalition is all in support. And here to testify today, I have Liz Heflin, who is the mother of Caitlin from Sonoma County, and do want to say thank you to Ms. Heflin. We have Joanne Kohler, nurse and case manager from Children's Hospital Oakland, and then Dr. Daniel Carlin, resident physician from UCLA Hospital. Thank you so much, Mr. Chair.
Thank you, and please proceed.
You want me to start?
Yeah, please.
All right. Oh, I pushed this?
You're good. You're good.
All right. Thank you. Even on the best of days where seizures don't come without warning. Hold on. All right. sorry. Okay. And Caitlin is pain-free. Her medical needs start before 6 a.m. And yes.
Let's switch if that's okay.
All right. Thank you.
It's not on, okay. Hi, my name is Joanne Culler. I'm a clinical nurse specialist in the neonatal intensive care at Children's Hospital in Oakland, and I strongly support this bill because it's something that I struggle with on a daily basis and that most of the nurse case managers at our hospital struggle with. As care has become more intense and critical in our hospital and more technologically developed, we are sending more and more children home dependent on technology. That is breathing machines, feeding pumps, suction machines, monitors, ventilators that they need to live on. We're unable to find the home nurses for these children. In our area, there are very few. I have 3 agencies that I can call for pediatric nurses. The list is extremely long. Many of those children have never, well, in my case, have never been home. They've been with us since birth and can be there for over a year, sometimes just waiting months to get home. I know in our pediatric units, they have about 13 companies they can call to care for older children, and sometimes they have year waiting lists, and many of those children have to go to care facilities, long-term care facilities, which are not in the area. The many problems with the children staying in the hospital are, one, it impacts our bed availability, but more than the most important thing is that it really impacts their development and their ability to bond and be with their families. Many of the mothers and fathers are unable to visit because they either live long distances away, have transportation issues, or have other children that have no child care for. If the child does eventually go home without nursing, which we have sometimes done, and trained the family, many of those people have had to give up jobs, which then puts them onto welfare also. When we have sent them home again without backup nursing, we see readmissions, we see ER visits go up, and we see many calls to the pediatricians or to the clinic. We also, I just sent a baby home on Monday, unfortunately cannot get nursing for, is on a BiPAP mask at night, on a ventilator, oxygen cannula during the day, on a continuous feeding pump through a gastrostomy tube, and the whole time coming up here on the train, I'm getting calls that the mom still has questions, and there's problems with some supplies that came that aren't the same, and there's just issues about him sleeping last night and the monitor alarming. And as much as we train them, they're not healthcare professionals, and we expect them to act that way. And so there really needs to be an increase in the pay for these patients. There are not nurses that are taking jobs in home care agencies. The pay at hospitals is much higher, so there are not nurses that are willing to take the low pay that is given to these agencies, or they start for a small amount of time to get some experience as a new grad and then move on. So we have other cases where we train the nurse, we bring them in to our unit, and we'll train them on the ventilator or the feeding pumps or whatever the child's going home on. And then after they get home and care for them a short time, the mom calls and says that the nurse quit. She got a job at a hospital. So it's a continual crisis and a real problem for our families. I urge your support on this bill, please. Thank you.
Good afternoon. My name is Dr. Daniel Carlin. I'm a physician in internal medicine and pediatrics in Los Angeles, here on behalf of the AAP today. I'd just like to take a moment and commend the bravery that it takes as a mother to come here in support of your child. It takes a lot to come in front of a committee. I'm here today to strongly support this bill. We see over and over again much of the same things play out that my colleague described, but one of the most heartbreaking things is to see family disruption and unnecessary hospitalizations that come from the inaccessibility of quality home health services for kids. We often have many patients actually in Los Angeles who are forced to stay in hospital for much longer durations than they would otherwise require. Sometimes we know that we can treat something within 3 days and send somebody home with antibiotics. Oftentimes they have to stay a full 3 weeks because they are unable to access IV antibiotic nursing services in their region. This is an exponentially more expensive way to practice care within pediatrics. Really, one of the things that I've seen, though, is that when we give quality care to children within their home environment, they do better. we can achieve similar rates of outcomes, we can achieve good control of infections, and we can do so in a way that keeps families whole and that allows children to be children. I strongly support this bill, and I hope you do so as well.
Thank you. And what was your name again?
Liz.
What's that? Liz?
Liz.
Liz.
Yes.
And then where are you from?
Windsor.
Windsor.
California.
And so tell me a little bit about your little one.
All right, this is Caitlin, and she's 14.
Good.
I won't cry this time.
No, no,
right.
so if you want, take as much time as you want, because I
Okay.
would much rather listen to you than him,
Oh, okay.
okay? So just calm
All right.
down, take your time, we can
I
have a
won't cancel out this
conversation,
time.
you know,
Okay.
because,
All right.
take your time.
Okay. Even on the best of days, when seizures don't come without warning and Caitlin is pain-free, her medical needs start before 6 a.m. and continue all the day through. I take her off TPN from the day before, change her cap on her central line, flush with saline and heparin. 4 hours later, I start the TPN again, all in accordance to the right protocols. Protocols for each entity in Caitlin's care are fundamental to her day being the best it can be. Her central line, GJ feeding tube, so gastrojejunal tube, medications, they all have specific protocols to keep her infection-free and taken care of. Once a week, I do an ethanol lock on her line to prevent infection. I am responsible for tending to her medication schedule. All need to be given at the right time and in the right amounts. Sorry. I lost it. Okay. Right now, she is on IV antibiotics, actually, and which I do through her line. And because of her complex gastrointestinal issues, she doesn't tolerate large volumes and is fed as much formula as she can tolerate through her gastrojejunal tube for 18 hours a day. I spread her medications out every 2 hours from 6 a.m. to 10 p.m. every day. I mix her formula to the right ratio every 4 to 6 hours. I change both of Caitlin's dressings regularly and in accordance to their specific protocols. I take her to all appointments, labs, keep track of her medications, formula supplies, TPN supplies, and order everything as it's needed. Even bathing has become a protocol. I help her with that and keep her line dry. I have emergency glucagon shots in case her blood sugars go too low, emergency seizure medication in case she has a big seizure that lasts too long. I keep the VNS magnet close to me at all times in case she has a seizure to swipe her VNS, which is a vagal nerve stimulator. Seizures come without warning and change our days on the ones they invade, but we still have to keep to her schedule. Some days she doesn't tolerate formula at all and is in constant pain. Other days her motility is so poor, her stomach drains bile out of a bag connected to her tube. If I don't connect that to drain, she's miserable and throwing up. It's my job to manage her needs as they change and constantly be aware of her schedule, how she's tolerating feeds, and make sure I'm doing everything I can for her. It doesn't matter if it's a weekend, a holiday, her birthday, every day needs to embrace her needs, and that has become our entire life. I can't take a day off or have a sick day or get too tired. As Caitlin's sole provider and only caregiver, this all falls on me. And while I would not change that for anything, the reality is that 24/7 care is all-consuming. Sorry. And we do need help.
Doing fine, just,
Okay.
don't worry, if you want to take a little breather,
Right.
you're good, just,
That subject's over.
nope, you're good.
Okay. Down to home nursing care. Caitlin qualifies for 16 hours a day of skilled nursing care at home. She gets none. There is no nursing care available to her. We have been on a waiting list for 1.5 years with no insight or tangible hope that it's changing. And she's getting, or that she's ever getting close to being, any care being available to her. In our county, there are 2 agencies who claim to provide RN-level care for pediatrics who will accept Medi-Cal. Caitlin has dual coverage insurance, but her home nursing care hours are covered in the Medi-Cal CCS portion. Because of that, and because of a system that is seemingly forgotten, where reimbursement rates are so low, the caliber of nurses willing to take that pay is often worrisome and unsafe. Medi-Cal does not lessen the importance of a patient and should not justify neglectful, unsafe, or intangible care. I can't imagine years-long waiting lists in hospitals for kids to get care. It shouldn't happen in home care, but it does, and for many kids. We had care from 2011 to 2014, and those 3 years I trained every nurse who cared for Caitlin. I do not in any way discount their license, but on-the-job training is important. Knowing Caitlin's care protocols, I realized quickly how lacking the home care system is. Protocols aren't known, medication and medical records aren't updated enough. For the first 3 years, I reported issues of my safety concerns, outdated forms, central line care protocols not being implemented, and more unsafe situations that directly affected Caitlin's care and safety to the agency itself. Regarding a central line especially, even one small error from not complying with known protocols could quickly become life-threatening. The issues I reported to the agency supervisors were not small problems, they were huge safety issues. Those reports stayed in-house and were not addressed. In August of 2014, after reaching out to legislators for guidance, thank you, I reported to the Public Department of Health my safety concerns for the care we had been receiving. I kept records of what happened, kept all emails, letters, forms, and within 2 weeks of filing that report of what happened, the private agency who I had reported about sent me a letter terminating any future care to my daughter. Since then, we have been on a waiting list, with the only other agency claiming to provide RN-level care for pediatrics. The investigation into the agency is still pending over a year and a half later. My hope and plea to you is to pass this bill and better fund pediatric home nursing care.
Thank you very much. You did a great job. So anyone
Thank you.
else would like to speak in support?
Thank you. Thank you.
You did a much better job than the senator, too.
Yay!
Much better job. Anyway, anyone else in support?
Chairman, Mr. Chairman, members, Randy Perry on behalf of the 8 California Children's Hospitals and California Children's Hospital Association in support.
Trent Smith on behalf of Partnership Health Plan and support.
Erin Kelly with the Children's Specialty Care Coalition in support.
Leonette Ide, parent of a child on a ventilator since she was 6 months old. She's doing great now, but we couldn't have done it without all of our nurses, and we cannot get new nurses now. They need a raise. It's been 15 years.
My name is Rana Hyde, and I support this bill.
My name is Carmen Ceballos. I'm a home care nurse for Premier, and I strongly support this bill.
That's all support. That's amazing. That's amazing.
Lydia Bourne, American Academy of Pediatrics, in support.
Susan Wu, pediatrician in Los Angeles and part of American Academy of Pediatrics, in strong support of the bill.
Braden Obrowski on behalf of the California Association of Health Services at Home, strong support. Thank you.
Moan Giacchino with Always Home Nursing and My Friends Pediatric Center is in strong support of this bill.
Chris Frank, Maxim Healthcare Services in support.
Sam Greenspan, Children's Hospital, Los Angeles, Len Public Health Fellow, support.
Dr. Angelica Zen with the American Academy of Pediatrics in strong support.
Dr. Mona Patel from Children's Hospital Los Angeles, AAP, and the head of a large complex care clinic in Los Angeles in very much strong support.
Tanisha Moss, pediatric resident at Harbor UCLA and member of the AAP in strong support.
Faisal Saba, pediatrician of the American Academy of Pediatrics with very strong support.
Kevin Fang, pediatric resident at Children's Hospital Los Angeles, and member of the Academy of Pediatrics. Thank you so much for your time and strong support.
Roxana Rangwala, resident at CHLA, in strong support.
Megan Reeves, pediatrician in Los Angeles, on behalf of the California AAP, in strong support.
Linnea Shetner with the Internal Medicine and Pediatrics Department, and in strong support.
Dr. Vijay Prasad, CHLA, resident, in strong support.
Monica Foster, pediatric resident at Harbor UCLA Medical Center, in strong support.
Melinda Palma, pediatric resident physician at Harbor UCLA, in strong support.
Colin Robinson, internal medicine and pediatrics, as part of the AAP, in strong support.
Casey Sherman, pediatric resident and member of the AAP, in strong support.
Barsha Puri from Children's Hospital Los Angeles, in strong pediatrician, strong support. Thank you.
Dr. Gladys Felix with the AAP, in strong support. Thank you.
Dr. Amy Ye, pediatric resident of Children's Hospital Los Angeles, in strong support.
Dr. Allison Faber, pediatric resident at Children's Hospital Los Angeles, in strong support.
Okay, is there any opposition to the measure? Any questions, comments from any of the members? Yes, Senator Nguyen. Oops, Senator Nguyen first.
Thank you, Mr. Chairman. Senator, I appreciate what you are trying to do. I have supported a number of these bills to increase California's dismissal reimbursement rates. What I wanted to ask, because this pilot program only affects 3 areas, LA, Bay Area, and Central Valley. I wanted to see if there's a possibility to adding Orange County into it as well, because we face the same issues in Orange County, just like any other the 3 counties that you've listed. Because facilities in my county are, very concerned that they will lose nurses to LA if these reimbursement rates are higher in LA than they are in Orange County, and then we're going to have shortages of not only the facilities but the nurses as well, because everybody's going to be going, because it's a good drive, even though it's a short and distant, a little long in time because of traffic, LA traffic, but you're looking at a 20% increase is drastic, and I would hate to have that hurt Orange County.
First of all, I do want to say thank you for your support on looking at Medi-Cal, and I think you're absolutely right. This has been a real challenge, to be honest with you. The way we looked at these 3 regions were based off of the number of shortages. So when we take a look at the most acute care in the state, and by the way, every county, large and small, has great need. But looking at where the worst case scenarios are, we're looking at the 9 Bay Area counties, the city and county of Los Angeles, and the Central Valley. And we're looking at a couple of variables. Number 1, the number of agencies that would be available. Number 2, the number of potential patients that should be served. You're absolutely right. Orange County is near the top. Would love to be able to take this statewide. It would take $50 million to be able to look at a 20% statewide. That would then be matched with additional $50 million from the feds. But right now, that's why we've looked at a very focused pilot project, because being candid, the Department of Healthcare Services says there is no access to care challenge. So despite all the proof, what we need to be able to do is have a pilot project to be able to show, number 1, a variable that home health care, we already know this, but we have to prove that out. Home health care is going to be it's going to be less expensive than it will for hospitalization, and that it's going to be better for the child. And we also have to show the department that with a 20%, that we're going to have increased access to care. And so that's a challenge. I'm with you, though. If we could expand this statewide, we should. And we actually have seen a decrease in pediatric Medi-Cal. Back in 2009, it actually went down 1%, in addition to not seeing rates go up for 15 years. So I think we should keep talking on that, because it is a significant issue. And again, I just want to say thank you, by the way, for the support of those bills.
Thank you. Senator Pan, have a question?
Yes, thank you. And I want to thank you, Senator McGuire, for bringing this bill forward. Clearly it speaks to another failure we're having in the Medi-Cal system, given the access issues. I guess the common question I want to ask you is that, as a pediatrician who actually was a CCS certified provider, I've seen patients like Caitlin in the hospital, and I know that, as was testified before, is we have patients, Caitlin has a fantastic mom who's able to juggle all of this full-time. That's your full-time job. And there's other patients whose parents or guardians or whoever's taking care of them can't do it. They have to, they're the sole working provider. They don't have the support, et cetera. And in fact, we end up having patients in the hospital for weeks or even months because there's no place, you can't send them home. They just, that's not manageable, all those things. That the child may die, you get infection and die. And so as we're looking at these pilots, and I would make note that neither of the 2 counties I represent are on the list, but as we do this, and because I don't Senator Probst, I need to make this comment, is that when we figure out how we actually price the cost of this bill, the appropriations. It's not that, do we give a 20% increase, and therefore what's that increase, and that's the price, because you're not taking account of the potential savings. And that I hope that there's an evaluation. Obviously, the first priority is the access to care and the quality issues, the outcomes. But since money is such a big deal here, and it is important, that we also track what happens on the financial side, because I think it would do us a disservice to say, well, if we expanded this from a pilot to the state, that the cost of this is simply take the 20% fee increase and multiply it out by all the other additional nursing time, because you're not taking account of the savings side. Yeah. Like how much hospitalization, like we need to identify, and I think that the other challenge is going to be, and I'm going to push for the department, I know they're not here, but they need to account for, they need to be able to collect that data from all those managed care companies that that are in these counties that are your pilot. A lot of them are managed care, and they don't have in the fee for service, at least you have utilization data. All right, they need to demand that data is collected so they can find out how many patients got discharged earlier from the hospital, so you can quantify all the hospitalization, avoidable hospitalization. All right, that needs to be, if you don't collect the data, you're not going to know. And so that's really important, and you're not necessarily always going to get that detailed utilization data under a managed care organization, system. So they'd have to require the managed care organization to work with the hospitals and collect that data. So we know what the true cost of this bill, which may actually be a net savings. I mean, that's a really important component in doing this. I hope that when approach looks at this bill, even for the pilot, they acknowledge that in their estimates, even if they can't quite nail the exact number, but acknowledge that their estimate may be an overestimate if they aren't able to account for the potential savings. But then in the pilots, there's actually the data collection necessary with the required utilization information from the managed care companies are existing in those pilot counties to be able to determine that so that we can decide what the true cost or true savings this program really entails if we spread this statewide, so that we can get to Orange County and Sacramento and Yolo and other counties as well.
I think you have hit the nail on the head, Senator. Thank you. We have to look at the cost savings. We know we know that we can provide superior care after hospitalization to be able to have that child at home. Number two, we know that there will be a savings when it comes to taxpayers. And what the pilot project, and I apologize, I did not cover it in the beginning, is we would require a report to the legislature after 3 years on nursing hours filled, state money saved, and decreases in hospital stays. And so that will be tracked within the pilot project regions to be able to do a report back to the legislature. And you're absolutely right, and it needs to start now when it comes to the appropriations. Thank you. And thank you for all your work, by the way.
Seeing no other comments, Senator Roth, yes.
A quick one. Do you think it's going to take 3 years to get meaningful data?
I think we're going to need to be able to have a trend. Yeah, and so I think it is going to take 3 years to be able to get there in regards to being able to get the program up and running, the tracking system in place, and then following those patients.
So, but for $100 million, we could do this statewide?
For $50 million on the state skin of the game, plus another $50 million from the feds.
So for $50 million in our general fund budget, we could take this statewide?
About 5,000 patients, pediatric Medi-Cal.
Well, we ought to continue to try to press for that and not wait for your data, frankly, but I'll be supporting it. Thank you, Mr.
Thank you.
Thank you. Seeing no other questions, is there a motion? Moved by Senator Pan. Senator McGuire, would you like to close?
Would respectfully ask for an aye vote, and thank you, Mr. Chair, very much.
Thank you very much, Senator. Item number 12, SB 1401, due pass to appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen? Nguyen, aye. Hall? Mitchell? Monning? Monning, aye. Nielsen? Pan? Pan, aye. Roth? Roth, aye. Wolk? Wolk, aye.
Currently at 6, enough to get out. We're going to place that bill on call. We're going to do the consent calendar at this time. It's item number 10, number 11, and number 13. We have a motion by Senator Wolk. Call the members, please.
Hernandez.
Aye.
Hernandez, I. Nguyen. Nguyen, I. Hall. Mitchell. Monning. Monning, I. Nielsen. Pan. Pan, I. Roth. Roth, I. Wolk. Wolk, I.
Okay, we're going to go to item number 1, Senator Pan, SB 877, reporting and tracking of violent deaths.